Thank you for your interest in this Let's Talk Medicine podcast titled An Australian Doctor in Africa, an Inspiration to All, proudly brought to you by the Australian Doctors Federation. I'm Dr. Chris Davis. The World Medical Association Declaration of Geneva requires members of the medical profession to solemnly pledge to dedicate their life to the service of humanity. As detailed in this podcast, Dr. Andrew Browning, AM, has honoured that pledge in a truly inspiring way, guided by his faith and his love of humanity. In a world where the practice of medicine is being profoundly disrupted by political, financial, and bureaucratic interests, Dr. Browning reminds us of what a dedicated and skilled doctor can achieve when free to practice their profession according to its finest traditions, primarily serving patients ahead of all other considerations. As such, every medical student and aspiring health practitioner is encouraged to listen to this podcast and read Dr. Browning's book. And for every medical practitioner who is feeling overwhelmed by third parties detrimentally intruding on the patient-doctor relationship, hopefully this podcast will help sustain them in their service to humanity. We go now to Dr. Aniello Iannuzzi, Chair of the Australian Doctors Federation, in his conversation with Dr. Andrew Browning, AM.
Dr. Andrew Browning, who is an inspiration to so many in the Australian medical profession and the broader community, and we have him here today to tell us about his career and his organisations that he runs, his missionary work and his insights into how the Australian medical system contrasts to the medical system in Africa. Welcome, Dr. Browning.
Thank you very much.
Okay, well, I really don't know where to start with someone like you. You've achieved so much and done so much, and I'm almost nervous to interview you because of all your achievements. But how about you give us just a little bit of a story how you ended up from a medical student in Australia to a missionary doctor who's done so much in Africa?
Well, the story started with you, I guess. We just found out that we were actually in the same year at Sydney University, but our paths have only just crossed now after all these years. Yeah, but primarily I'm a Christian, and I always thought I'd be a missionary doctor, even from the age of 6, going to church and Sunday school in my hometown of Bowral and listening to missionaries return from the field speak to our church. I thought, yeah, this is maybe what I would do with my life as a doctor. So had my medical elective from Sydney University in Tanzania at a mission hospital. And that really confirmed that that's where I might take my career. So yeah, after graduating as a doctor, I spent time in Ethiopia. Got a lovely job as a fistula surgeon in Ethiopia with a lady called Catherine Hamlin. But the Ethiopian health department said I have to get my training in obstetrics and gynaecology before they would give me a work permit to stay in Ethiopia. So returned to Australia, did actually got MRCAG first, later FRCAG through Britain. And then as soon as I got that, I moved to Ethiopia to take up my post there.
Was there a reason why you did it in England? Was the training simpler, less red tape?
All of the above. So at that time, for the obstetrics gynecology training, you had to do these 10 modules as part of your primary thing, and they were extraordinary, enormous amount of work. I don't know anyone who actually completed them all. Each module would take hours and hours and hours, and days, months of work, and it wasn't really stuff that you needed to know. I'd much rather get into the real science behind that a primary, traditional primary exams were based on to help me understand the science of what we were doing in obstetrics and gynecology. So fortunately, I was able to do the MRCAG, which is actually a lot quicker. I was very young and impatient and just wanted to get my certificate, whatever certificate that was, that would please the Ethiopian Health Department. And so after only 2 or 3 years of studying to get my MRCAG, I was able to get into Ethiopia. Whereas if I went through all the modules that you had to do for Australia, then the secondary exam, the whole thing would have taken at least 6 years, maybe 7 years. I cut it down to less than half the time. And Catherine Hamlin, my boss at that time, was very impatient for me to get there as well. She was getting elderly and she wanted me trained up in fistula surgery before she wasn't able to do much in the hospital anymore. So for all those reasons, time-wise, simplicity, wise, usefulness wise, and the MOCG is so well recognised around the world. It's served me very well. I'm very blessed. Although I'm back in Australia now and can't work as an obstetrician here, but I've got no intention of working as an obstetrician in Australia.
It's something that may happen a bit during this conversation. We might go off onto tangents and comment on the Australian medical system. I have worked most of my career in a rural area, and we have troubles accessing specialists and doctors, as is well known. Obviously not as extreme as perhaps in Africa. And the issue of specialty training and red tapes and hurdles is an issue that I think perhaps in Australia we should be tackling. When we struggle to get obstetricians in places like Dubbo, Wagga, Tamworth, for example, inland New South Wales, I often think to myself, why do they need to be leaping through all of these hoops and these specialty training programs that are so long, when 4 years of very focused specialty training may in fact serve the regional areas well. And the model that used to be the case here, some countries still retain, where you get your membership, which is basically a general specialist, and then you can go on to your fellowship if you want to have the teaching hospital or professorial position. I think there is some merit in looking at that again in order to improve access and also get rid of this backlog of trainees that just can't get through the specialty training system in Australia. So your experience, I think, is a good illustration of what that more focused, occupationally orientated specialty training could lead to.
Yeah, it's interesting that I've worked in some countries that have a degree of bureaucracy and red tape in Africa, and I've worked in countries that are very new, like South Sudan, or countries that have been at war for many years, like Central African Republic or Sierra Leone. And fortunately, in those countries, the red tape is negligible because everything's broken, and the administration just wants things to happen quickly. And you can really get in there. You can build hospitals, you can do a lot, you can train people. But as countries settle and develop, the administration seems to compound and compound and compound. And I think in Australia, coming back to Australia after 20 years away, you've really noticed a huge step up in the amount of red tape. The red tape just seems to be added and added and added of layers of bureaucracy that you can see why it's been introduced, that it's making things on the ground far too complicated and unwieldy. Like in Britain now, I mean, you've got people leaving just fed up with the NHS because they can't progress through the training system. To get these little boxes, you just become a slave to this system rather than having the wider picture of, becoming a good doctor and actually looking after the patient. Almost glad I can't be registered as an obstetrician in Australia, to be honest with you.
It's interesting to hear someone like you say things like this, because at the Australian Doctors Federation, we're often railing against the amount of red tape and bureaucracy.
Oh, keep going.
Thrown in front of us, and I think GPs and rural communities are often collateral damage in all of this, because as everything gets so burdened with red tape, it's very hard to keep one's credential as a hospital or as a GP, etc. And all of a sudden you have to jettison your skills or jettison services in order just to comply with red tape. And
as a charity too, the amount of red tape that you have to comply with to maintain your charity status, to almost enforce Australian systems on the hospitals in Africa to enable us to fund. And so it's not only in medicine, I mean, it's just the whole charity sector's just strangled by red tape. It kills work, and it kills productivity, and it kills care of patients. So I wish administrators could see that, and some honest administrators do see that, but it just seems impossible to wind that backward.
yeah, let's talk about Dr. Hamlin. She's a legend in Australian medical history. For those who haven't come across that name, could you give us a little summary of what she did, and then perhaps contrast that to the countries you've worked in and how you've continued on with that style of work?
Yeah, so Catherine and her husband, Reg Hamlin. Catherine was a doctor in Australia and married Reg, who was a New Zealand doctor, but became an obstetrician in Australia. And they moved to Ethiopia in 1959 to start a midwifery school. But they soon realised the problem of the fistula patients in Ethiopia, but no one knew how to repair them back then. So they developed the work of James Marion Sims and another guy called Lawson, who had done some fistula work in Nigeria, Lawson had, and Sims before that in America in the 1800s. Further developed the surgery for fistula, obstetric fistula. and started treating patients in Ethiopia and Addis Ababa in the government hospital and getting success. So they got more and more patients coming to them. And so they're so inundated with patients at the government hospital that they had to build a separate hospital altogether to care for them properly, because they weren't emergency surgery. They'd be put back and back and back on the waiting list while the other emergencies came on. Because they were leaking urine with this obstetric fistula, the other patients didn't want them in the ward. So there's stories of patients waiting in isolation for 3 years in the hospital waiting for them operation. So the Hamlins thought, we must build a hospital. So they built and opened their fistula hospital in Addis Ababa in 1974. Red continued working and died in his 80s in 1994 or 5, I think. I visited Catherine in 1996 in Ethiopia after Reg had died, and she was in her 70s at that stage. Reg was quite a bit older than Catherine, and I joined her in 2001. So I worked with her for 10 years, 5 years in Addis Ababa. Then my wife and we moved up to northern Ethiopia to start an outreach hospital, the fistula hospital, in a town called Bahadar. So we ran that for 5 years in a more rural area of Ethiopia. And then I started my own charity to do what Catherine had started in Ethiopia with her husband, Reg, to the rest of Africa. And also, more importantly, to do prevention work. Obstetric fistulas due to lack of access to safe obstetric care. Women don't have access to hospitals. They die in labour. They get fistulas. They get injured. Babies die. And we reduce all of that by having hospitals for them to deliver in. Yeah, we moved to Tanzania in 2011 and started a fistula service there. And from there, been all around Africa starting fistula units and training people, and even in Southeast Asia.
How many countries are you active in these days, and how many hospitals do you estimate that you've set up?
Set up or been part of setting up, I don't know. I'd have to sit and think. The ones that the Barbara May Foundation have set up is 3 in their entirety, 2 in Ethiopia and 1 in Tanzania. We've partnered with the Lutheran Church to build another one in South Sudan. We're building another one in Uganda and another one in Tanzania at the moment. So that will be 6 hospitals that we've built and established and run. How many I've partnered with to help set up? I don't know, maybe another 10 perhaps around Africa and Southeast Asia. I'd have to think and add them up.
So in addition to fistulas now, you're also offering general obstetric services. You mentioned prevention. Does that include other services as well?
Yeah, so prevention is multifaceted, really, because it starts in the villages. These women in the villages, they have poor education, if any education at all. And so they might think in their village that 2-day labour is normal, and then they'll only start seeking help in labour from their village if they've been in labour for 2 days. And then they might not have transport, they might not have communication, they might not have any money. So you need to be educating people to get to hospital early. So don't let the sun set twice on a labouring woman is a common phrase that we use. And then they need to have a plan to get them to hospital. We can provide transport if need. We have waiting areas where they can come from 36, 37, 38 weeks and wait with us if they're living far away or if they have a complication. So they live close by the hospital, so they can just come to the hospital and get obstetric care at the right time. And the care has to be free. I mean, these women can't afford even the transport sometimes to get to the hospital, let alone any care in the hospital. And last year, we provided free delivery for 16,000 women. No fistulas, thankfully, out of those 16,000 women. Yeah, but we did have 8 maternal deaths. And although those 8 maternal deaths were in the Afar region of Ethiopia, it's the hottest inhabited place in the world. Very, very difficult. Probably one of the most under-resourced areas in the world. And there's famine there. There's been conflict with rebels. There's been fighting. Then there's been drought, famine, locust plagues. So there's a lot of malnutrition. And those 8 women died just purely because they were so malnourished, their bodies couldn't handle labour. So actually, with the hospitals in the Afar Desert area, we've been supporting many thousands of women, pregnant women and lactating women with food supplements, emergency food relief.
Well, with the education you're providing and the service you're providing, the rate of fistulas is much lower now, which is fantastic.
In those areas where we work, I mean, overall, the world has made big steps towards improving maternal mortality and morbidity over the years since the Millennium Development Goals were put in. It's a bit hard to know if those figures that are printed are true or not. Some of them, it's a bit hard to collect accurate data. But being on the ground in countries like Ethiopia, Uganda, we do see less fistulas these days. We still see them, but less. So there's more hospitals, more health professionals, more access to safe obstetric care. We've been part of that solution, just a small part. Governments and other missions and charities have played their part as well. But in countries that have had difficulties like Somalia, Central African Republic, DRC, South Sudan, now probably Sudan as well because of the problems in Sudan, they still have a huge problem with obstetric fistula.
Our audience is made up a lot of our members who are medically trained, but we do get a lot of general public looking at these podcasts as well, and some of them may not understand what a fistula is. I noticed from your book that the best way to get a lot of these messages across is via stories. So perhaps you could tell us a story of a patient or two, how it led to a fistula, and maybe how your foundation and hospitals have intervened to change people's lives.
Sure. I mean, I could tell you many stories. I've been part of the care of about 15,500 fistula patients in my career, and I don't know which story to pick, but I'll tell you a story of which illustrates well why women get fistula, and also illustrates well what to do to prevent it. There's a story of two sisters from northern Tanzania, Masai girls, twins. They were delivered in their village in northern Tanzania, a very poor area, just living in mud huts, grass and twigs from their roof. The boys look after cattle, the girls would dig in the field or milk the goats and cook and so forth in the village. Anyway, the mother had a sister who didn't have a child, and it's quite common in that culture if you've got a child of your own and you've got another child, you can give one child to someone in your family who doesn't have a child. I mean, the nuclear, they call all aunts and uncles mothers and fathers, and so everyone's a mother, everyone's a father in that family. Two sisters, Namnyak and Namboy. So Namnyak went to live with her aunt, and her aunt moved to Arusha, which is several hours walk away, then a few hours drive away. And she grew up going to school, and her aunt had a job, so they had a small income. Namnyak got pregnant, probably married and then pregnant at probably about the age of 18 or 19. She went into labour and was having difficulty in labour, so knew through her education, and she had some resources, that she should get to hospital. So she went to hospital, needed an emergency caesarean, and had a safe delivery, which probably saved the baby's life and could well have saved her life as well. Her sister, Namboy, stayed in the village with her mother and never went to school, just spent the days digging in the land with a hoe, looking after the small animal. Couldn't read or write, no education, no income. She also got married about the age of 18 or 19, got pregnant, went into labour. And in that area of Tanzania, they think a 2-day labour is normal. So she was in labour for 2 days in the floor of her mother-in-law's hut, hadn't delivered. And they thought, gosh, where do we go to get help? Should we get help? How can we get help? There's no communication, no roads, no transport, no hospital nearby. So she stayed in the village and laboured for another 2 days, and unconscious on the floor of a hut after 4 days of labour, delivered a stillborn child. Took 2 days to regain consciousness, and when she did regain consciousness, she was leaking uncontrollably from her bladder. Because she'd been in labour for so long, the baby's head was pressed against the bones of her pelvis, and the intervening tissues, bladder, vagina, bowel, vagina, all had ischemic necrosis, blood supply cut off. Those tissues died, and they came away leaving a big fistula, or a hole between bladder, outside world, and sometimes also the bowel and the outside world as well. But in Namboy's case, it was just from the bladder to the vagina, a big 6-centimetre hole. She was divorced by her husband because she leaked urine and smelt. She was kicked out of the house by the mother-in-law. She went to live back with her mother. Her mother didn't want her in the house really, so she lived on the edge of the family compound in a separate hut for 18 months, ashamed and depressed. She was found by our outreach team who came to teach that area about maternal health and fistulas, and heard that there was this lady called Namboy, so our outreach team went to visit her. She knew she was a fistula patient and brought her to our hospital. Little Namboy had a severe, unusual reaction to the anaesthetic, we believe, and had a cardiac arrest on the table. We did CPR for probably half an hour, far too long, but got her heart rate back and her breath back, but arrested again. We did CPR. We can't ventilate or anything there, so we did CPR for another 20, 30 minutes. Again, thinking, oh my goodness, should we stop? It's very hard to stop, isn't it, when someone's so young? But we did get some gas back, and she recovered, but she must have been very cerebrally irritated. She was just screaming and very irritated. We thought she must have severe brain damage from hypoxia. I don't know how, but we praise God that she just made a complete recovery mentally and cardiovascularly, but we hadn't operated on her. I had to leave Tanzania. I came back again in 2 months. We operated again, and thankfully she was completely cured of a fistula, which she was very happy about. But little boy, I mean, she's only 20 or so now, but she's been through a long, difficult labor, dead baby, fistula, divorce, died twice. While her sister, exactly the same, had access to a hospital, had a cesarean. She's got a live baby, still with a husband. She's fine. So two women, yes, two very contrasting outcomes, purely because they weren't aware they had to get help and they couldn't get help. So a lot of what we do in the villages is to teach people to get to hospital and we provide free care and transport to our hospital to have a safe delivery. And if they do have a fistula, then we bring them to the hospital to care for them there and operate and restore their dignity.
Wow, that's an amazing story. It's quite incredible, the work that you do. What about the issue of funding these activities? I'm sure that's not an easy thing to do. And I'm sure there's not Medicare in those sorts of countries. So where does the money come from?
Yeah, it comes from mainly Switzerland, actually. Switzerland's our biggest donor, foundation-wise. But most of it, the biggest donor base we have is in Australia. So I started a charity in 2009 to fund all this work. Yeah, it's called the Barbara May Foundation, and it's a tax-deductible charity. And yeah, we raise money in Australia, Switzerland, America, England, and the money comes through there, and we're able to disperse it to our hospitals. And it doesn't cost that much, really. I mean, just on average, throughout our hospital network, for a lady to have 4 clinic visits while she's pregnant, including ultrasounds, blood tests, then a delivery in our hospital, 14% chance of needing a cesarean, postnatal check, and immunise your baby, cost 250 Australian dollars. We get
That's less than a single visit to an obstetrician for a consultation.
Yeah, most likely true. And it's interesting, most of our staff, the midwives do the majority of the work. They'll treat PPHs, they'll do assisted deliveries, they'll treat eclampsia. And the doctors just comes in and swaggers about and does a cesarean, and that's about it. And they're not obstetricians. We train intern doctors and even assistant medical officers to do a cesarean. That's a grade of health professional higher than a nurse and lower than a doctor, kind of in between those two cadres. And so in our hospitals at the moment, we've only got one obstetrician and getting marvelous results. So you're talking about all that training and so forth before. Yeah, you don't need all those certificates to do a good work, do you?
You mentioned the inability to ventilate patients. What do you do for anesthetics there?
Oh, sorry, to ventilate long term. So we have anesthetics. And actually, when I was first working we started that hospital in northern Ethiopia, that fistula unit there. We didn't have a anaesthetist, and so I did the spinals myself, and then went around to operate. Then later taught one of the nurses how to give spinals. We only had lignocaine spinal at that time, so we had to make sure our operations were finished in an hour and a half. And we later got some bupivacaine. Then we taught the nurse how to triple in some ketamine if the operation took a bit longer. But yes, sorry, we don't have an ICU to ventilate anyone in there. We can ventilate during an operation. We do more and more. We're seeing iatrogenic fistulas and ligated ureters as more doctors and health professionals are trained to do cesareans, but they're trained in a rather rushed way and they're not protecting the bladder. So we do see more iatrogenic fistulas and ligated ureters. So we do a number of laparotomies to reimplant ureters these days. Yeah, so we have general anesthetics for them.
And money's one thing. What about getting the equipment and things like the medications, the operating theatre equipment, etc.? Where does that all come from?
Yeah, you can buy all of that in country, of course. Some of the equipment is not great quality. So when we're setting up a new hospital, we do like to get equipment from Australia or America. And there's many organisations that stock up a container full of theatre equipment, theatre tables, and send it over. Some of it's problematic because you can't, many people just give broken things and think, oh, that'll do, they'll need that. But it's just very frustrating. I mean, they're dumping all their disused material on us, but a lot of other organisations do treat us very well and give us really nice equipment. So theatre tables and theatre lights and autoclaves are the hardest thing to get really good quality, and most of those we like to get from abroad. It's hard to get good quality in country. They seem to be quite cheaper ones that not such good quality. So similarly with sutures, you can buy sutures everywhere, but poor quality. The needles will break and the sutures might break and so forth. And so sometimes we import them, sometimes we buy locally. But almost everything you can buy locally, but some things are more difficult, like ureteric catheters. I'm leaving on Saturday to South Sudan. We don't have any ureteric catheters there, so I've been scrambling around these last couple of days trying to get some ureteric catheters to take with me. And special sutures too on a 5/8 needle, which is lovely to work with. We can't find anywhere in Africa good or poor quality, so I get those donated actually from America, and they arrive on my doorstep here in Australia, and I take them over in my bag.
So the Barbara May Foundation, I think that was named after your auntie, is that right?
My grandmother, actually.
Your grandmother, sorry. Can you tell us a bit of the backstory there?
A bit of a backstory. I've got also an aunt who's been working in Ethiopia since 1974. She's truly a remarkable woman. She lives in the Afar Desert of Ethiopia, and that's what brought me to Ethiopia first, to try and work with her with this nomadic tribe in the desert. So on top of that, we had I've got a remarkable grandmother, or had a remarkable grandmother, and my Aunt Val's mother. And she was actually orphaned, and her sister was orphaned in the Spanish flu in 1919. So she and her sister were little orphan girls, lived as little orphan girls, as you can imagine they might. My grandmother got married to my grandfather, and he was a very strict man, and grandmother was really the life and soul of the family, and really the matriarch. She had 8 children, a very godly lady, and used to pray for all her 8 children, and prayed for all her, actually I'm not sure how many grandchildren, and led by example. She lived a very simple and altruistic life. And at her funeral, there were 72 descendants from this little orphan girl, including, if you include all the married ones, the in-laws, and a lot of us involved in philanthropic work around the world. So quite a legacy from this little orphan girl, because she used to pray for us every day. And so we named it after her, the Barbara May Foundation.
Fantastic, fantastic. We recently did a podcast with a professor of metabolic health at Sydney Uni as well, Professor Luigi Fontana. We were talking about what contributes to a long and happy life, and as well as all the metabolic things, etc. One of the things that Professor Fontana talked about was the need to have good social networks, community, sense of belonging. One of the things I think that always stands out when we hear stories like yours are that the people, even though they may not have a lot of material possessions, they tend to be happier in many ways. How, as a doctor and as a missionary, have you found that to be? And do you have any advice for Australian doctors and the community with respect?
Yeah, I think, I don't do much medical work, if any, in Australia, and I work in a clinic helping patients with pelvic mesh complications, just as a CMO in the RPA, just while I'm in Australia, just one day every week or two. And it's often not what the patients, what they need is just want to be heard often and understood. And even though of course we offer management for them and symptomatic management for them, but they're so appreciative, and they're really happy if they just listened to and cared for and loved. I think that really is the best medicine, isn't it? I mean, if I could illustrate with one story,
Of course.
from Ethiopia, I think it illustrates it very well. I mean, the patients I used to treat in Ethiopia, northern Ethiopia, with their fistula, routinely depressed. 40% had attempted or thought about suicide, all in tears, all isolated. You'd meet these patients, they were so ashamed, they wouldn't even lift their head up to look you in the eye to greet you. They'd just be having their head down low, just completely embarrassed and ashamed. But one day I met a lady who was completely different, and she wasn't divorced. I met her on being carried into the hospital on her husband's back. She had been suffering with a fistula for 25 years, and her husband didn't leave her. And she was also actually paralyzed. The long labor had affected the nerves to her legs, so she couldn't walk. And so she'd been lying on the floor of her hut for 25 years. Her husband stayed with her, fed her, cleaned her, washed her, changed her, took her out into the sun to sit in the sun on a sunny day, brought her back in, never left her for 25 years. He heard through the grapevine that someone with her condition could get treatment in this town that I was living in, Bahadar. They were poor. They didn't have any money for bus fares or anything like that. So he carried her on his back for 3 days to get to Bahadar. And when I met them, I mean, I've never seen such love and such just happiness and composure just radiate from a couple. I mean, she was on his back. His urine and feces down his back. He had ulcers on his feet from carrying her over rocky roads for 3 days. But their joy in their face was just undeniable. So she was full of joy when other patients in her situation were so depressed. And she was like that because she'd just been loved and cared for by her husband. And she accepted that love, and he loved loving her because she loved him in return. And he slept beside her bed, didn't leave her side during the whole hospital stay, helped her get out of bed, and she was cured, and he carried her home. Yeah, remarkable man. And I mean, that really taught me the power over medicine of love. I mean, what people don't necessarily need to have a fit, able body with the physiology of a 25-year-old, but what they do need is to be loved and cared for.
Well, that's a fantastic way to wind up this conversation, I think. Now, we're going to put show notes linking to your book, A Doctor in Africa, for more inspirational stories, and we'll put links in our show notes to your foundation, and hopefully some people might think about how to donate or think about donating. What about for doctors and other clinicians in Australia who may want to contribute more than just money and prayers? They might want to contribute equipment, or they may even want to come and help you in some way. Are there ways to do this, or is that
absolutely
in a way?
Yeah, no, predominantly our staff are locals, so we've trained up locals, and that's what we want. We don't want them to be reliant on us. But there is a place for volunteer obstetricians and midwives to work alongside our staff, especially as we start new hospitals, to train up the new staff. So we're fortunate we've recruited a couple of midwives for our new hospital in Uganda. They'll probably go over mid next year, God willing. Yeah, we need obstetricians and midwives for the new hospital in Tanzania when that gets up and running. So yes, if you're that sort of person, as we say in Tanzania, karibu.
And is that something they do through your website?
Get in touch with us through the website.
And what about general doctors and general nurses? Would they have a role, or do you
There's
need...
a role, probably not in our hospitals, but there's a role in many others, mission hospitals, government hospitals, NGOs, all of those. They're often looking for people who apply to the Red Cross, MSF, or missions, or directly to the hospitals themselves.
Fantastic.
It's hard work, it's confronting work, and it's not for everybody. And a lot of people that go there turn around and come back quite quickly. But for a lot of people, it's life-changing. And you really realize that you can make a big difference in this world and the lives of other people with very, very little. And that's what really counts in this world. As Winston Churchill used to say, that it's not what you get that marks off achievement, it's what you give that leads to a happy life.
That's a perfect way to end. Dr. Andrew Browning, it would be not a far stretch to say that you're the most inspirational Australian doctor in practice at the moment, anywhere on this planet. I really appreciate your time, and may God continue to bless your work. And hopefully those looking at this video might be inspired to assist you in some form. So thank you very much. And it's been a great honour to interview you for the Australian Doctors Federation.
Yeah. Thank you very much. It's only as God enables, and He's certainly provided.